Disclaimer. This video content is AI generated as educational purposes only and is not a substitute for professional medical advice, diagnosis or treatment. Your health concerns may be unique. Always consult your physician or a qualified healthcare provider for personalized guidance.
So imagine this. You're just going about your day and all of a sudden, you're seeing two of everything. It's a really alarming feeling, right? But for doctors, it's actually the first clue in a fascinating medical investigation. Today, we're going to grab our detective hats and crack the case of double vision.
Every great mystery starts with a single, powerful clue. And in this case, it comes straight from the patient. I close one eye when I want to read, and it goes away. Now, that might sound like a simple observation, but for a medical detective, believe it or not, that one sentence is the key that unlocks this entire puzzle. That's right. When a patient shows up with sudden double vision, or diplopia as it's called in the medical world, their doctor has to become a detective. There are so many possible causes, you can't just guess. You have to follow the evidence, follow the clues, and piece together what's really going on. Okay, so let's get into the actual detective work. Every investigation starts with asking questions, right? But with double vision, there is one question that is so important, so crucial, that it instantly cuts the list of potential culprits in half. This is it. This is the big one. Does the double vision stick around if you close one eye? The answer to this single question sends the entire investigation down one of two completely different paths. So think of this as the first major fork in the road for our detective. If the double vision is still there even with one eye closed, we call that monocular diplopia, the problem is almost always physical, something in the eye itself, like an issue with the cornea or the lens. But what if the double vision goes away when you cover an eye? Well, that's binocular diplopia, and this is where things get really interesting. It means both eyes are working fine on their own, but they aren't aligned. They aren't pointing at the same spot. And that tells our detective that the problem isn't in the eye, it's a neurologic mystery. So once we know which path we're on, the detective brings out two main tools. First, a really detailed history, just listening to the patient's story for those little clues. And second, a systematic physical exam to find hard evidence. And get this, one study found that a whopping 70.5% of cases are solved with just these two steps. No fancy tech, just classic, old-school detective work. Okay, so remember our patient's first clue? Their double vision goes away when one eye is closed. That means we're on the neurologic path. And the very first place our detective is going to look is at the wiring, the super delicate cranial nerves that control every single tiny movement our eyes make. And here's why these nerves are the prime suspects. More than half, over 50% of all new cases of this kind of double vision are caused by a palsy, which is basically a weakness in one of these nerves. It's by far the most common culprit in the lineup. You can think of this table as our detective's wiring diagram for the eyes. There are three main circuits, the third, fourth, and sixth cranial nerves. Together, they're responsible for moving the eyes in every direction you can think of, up, down, in, and out. A problem with any one of these wires can throw the whole system out of alignment, and boom, you've got double vision. And what's amazing is how specific the clues can be. Just take a look here. This is what happens when that third nerve, the oculomotor nerve, stops working properly. The muscles that pull the eye up and in get weak, so the eye just kind of drifts down and out. You often see a really droopy eyelid too, but the biggest, most urgent red flag is the pupil. If it's wide open and dilated, a blown pupil, that can signal a true medical emergency. Why? Because the nerve fibers that control the pupil run along the outside of that third nerve, which means they're the first thing to get squished by something dangerous like a growing brain aneurysm. But what happens if the wiring seems to check out? All the nerves look good. Where does our detective turn next? Well, maybe the problem isn't the wire itself, but the connection point where the nerve signal actually meets the muscle. So let's bring in a new suspect, myasthenia gravis. This is an autoimmune disease where the body's own immune system starts attacking the signal receivers on the muscles. So the nerve sends a signal out just fine, but the muscle just can't hear it properly. And that leads to weakness. Now, this is what makes myasthenia gravis, or MG, such a tricky character. It's famous in the medical world as the Great Mimic. It's a master of disguise. It can create symptoms that look like almost any other eye movement problem, with the key exception that it doesn't affect the pupil. It can be a real chameleon. So, how does our detective unmask this master of disguise? It all comes down to timing.
For myasthenia gravis, the pattern of the weakness is everything. It's not constant. It gets noticeably worse with use, like at the end of a long day, and gets much, much better after a period of rest. This unique pattern of fatigue is the absolute dead giveaway that points the finger straight at MG. Of course, any good detective knows you can't get tunnel vision. You have to consider all the possibilities. So beyond faulty wiring and bad signal receivers, there are a few other culprits that need to be in our lineup. First up, we have thyroid eye disease. Now, this one's different. The problem isn't with the wiring or the signals. It's purely mechanical. The muscles and the fat behind the eye actually get swollen and inflamed, and they start to crowd the eye socket. This physically restricts the eye from moving freely. It's like trying to move your arm inside a jacket that's way too tight. And the biggest clue? You can often see it right on the patient's face, a distinct bulging of the eyes. Next in the lineup is a suspect with a real mouthful of a name, internuclear ophthalmoplegia, or INO. Don't worry about the name, just think of it as a communication breakdown. There's a problem in the brainstem that messes up the coordination of your eyes when they try to look from side to side. And the best clue here often comes directly from the patient. They'll describe a very specific feeling. It feels like one eye has to catch up to the other. That little lag is the classic calling card of INO. So, our detective has gathered all the evidence. The patient's story, the pattern of the weakness, which direction the eyes won't move, the size of the pupils, all the pieces are on the table. Now, it's time to put it all together and finally solve this visual puzzle.
And this is how it all clicks into place. A very specific problem, moving the eye, especially with a blown pupil. The problem is the wiring, a cranial nerve palsy. Weakness that gets worse throughout the day? That's a problem with the signal receiver, myasthenia gravis. Bulging eyes? That's a mechanical issue, almost certainly thyroid eye disease. And that catch-up feeling when looking to the side? That's a brainstem connection problem like INO. Every clue leads to a specific culprit. Case closed.
And really, that's the big takeaway here. Suddenly seeing double is, no question, a scary experience. But it's not some random, unsolvable mystery. It's a puzzle. And by methodically following the clues, starting with that very first question about one eye versus two, doctors can use this logical process to turn a really frightening symptom into a clear, concrete diagnosis.
Which kind of leaves us with one last thought. When you think about it, from aneurysms to autoimmune diseases to strokes, the way our eyes move and work together gives us this incredible window into the health of our entire nervous system. It really makes you wonder, what other hidden stories are our eyes trying to tell us about the amazing, complex workings of our brain and body?